Our next talk is newer anti-thrombolytic agents by Dr. Dheeraj Khurana sir. I would like to request Dr. Dheeraj Khurana sir to come on the stage. And the panelists are Dr. R.S. Jain sir and Dr. Pushkar Gupta sir. Dr. R.S. Jain sir, he is a senior professor in Department of Neurology, SMS Medical College, Jaipur. Dr. Pushkar Gupta sir is the Director of Neurology, C.K. Birla Hospital, Jaipur. I would request Dr. Arun Agrawal to come on the stage to present a bouquet to the speaker and chairperson. Nitesh, slide.
Good morning, everyone. The next presentation is on newer anti-thrombolytic agents by Dr. Dheeraj Khurana. He is a faculty in PGI Chandigarh. And one more aspect that we are well aware of is that he is a superb singer as well. So I invite Dr. Dheeraj Khurana for his book.
So there is a very small thing. Please keep your mobile on silent mode. Thank you very much.
Good morning, everyone, and thank you for the introduction. First of all, it's indeed a pleasure to be here at the Stoke Conclave in Jaipur. I thank the organizers and Suresh Gupta for inviting me here. While we connect, as usual, problems with the Mac, we lose time. We don't have to lose time in treating strokes, first principle. But Macs have their own problems. So today what I'm going to be talking of is newer thrombolytic or new thrombolytic agents. So what I would be covering is not only new agents, but also expanding indications of already existing thrombolytic agents like TPA. Chiefly, we have certain new indications coming up, and also the expanded time window, which also I would call it as a newer indication for existing thrombolytic agents. Okay. Okay. I think we're good to go. So, like I mentioned, we have what do we know till now? There has been a plethora of knowledge which has been accrued till date in the field of thrombolysis. We started slow. We started with a trickle back in 1995 when we had TPA getting approved, and there was a large gap when the next expansion took place. And recently, now in the last 5 years, the whole field has changed with intervention coming in a big way. It has changed the field of training of neurology. A good number of neurologists who are going into intervention, the way we are saving lives, it's a changed field in the last 5 years, and the most exciting time, I would say, in the field of neurology and stroke. So what we know till now is, as evidence-based and officially, or as guidelines state, TPA is the only proved thrombolytic agent till date. It's based upon a huge mountain of data starting from the NINS trial, going on to number of registries, and of course the major trials like ICAS-3, which helped in expanding the time window. And tenecteplase is the other agent. It has had a place in the guideline, but I'll talk of that. There has been certain change again in the present world, and just in very right in this year. And although it is India happens to be the only country where it got an approval a few years back for reasons best known. The dose was controversial, and so was the approval. But now I think we have reached a juncture where we have a good deal of knowledge to really talk of tenecteplase in light of the current existing comparator too. So what is new in TPA? First of all, there are two major things which I will talk of. Window period, which was also touched upon by Shri Jitesh. And second is expanding indications for TPA. So the milestones of thrombolysis, I would not go into the details. There was initial trials which were done with streptokinase, which were big failure, so it is out of question. RTPA, the first landmark study of 1995, which led on to its approval, and became approved in 1996, a very rapid approval, I would say, since there was no available treatment at that point of time. And so thereafter, a number of studies and a huge mountain of data in the registries, which helped us understand that it is safe to use in usual clinical practice. And we know that it works. Definitely it works. And it is being routinely used across our country in so many stroke centers, primary or comprehensive. And people are no longer afraid to use TPA, which is a great thing. So what about window periods do we know of? The trigger beyond the 3 hours happened when a meta-analysis was done, and this was the initial thought we had, that these are the odds of recovery. As time elapses, we know that the chances of recovery are low, but this does not touch the zero baseline, which is the benefit for TPA. And the odds, since it's a ratio, so I won't go into the statistical details. In a ratio, 1 is the baseline. Anything which crosses 1 is ineffective. Whereas if it is a single entity, like a single number, we take 0 as the cutoff. So it's still not crossing the 1 line, which meant that there is still some effect of TPA beyond 3 hours. And the pooled analysis, which was done later on, clearly showed that up to 6 hours, there is some benefit of TPA, which triggered the search for a expanded window period. And the first success story was the ECAS-3, where we broke the sound barrier of stroke, published exactly somewhere around 15 years after the first approval of TPA in 3 hours. And there it was seen that people who were treated with TPA versus placebo definitely did much better within the 4.5 window period. And the per protocol population too, it was seen in a similar way. And if the global outcome was, the odds were 1.28 and the numbers needed to treat were 1, if we just compared between 3 to 4.5 hour window period. And the age at that point of time was below 80, because that was one of the criteria used in that study. And so were certain other criteria like diabetics and people who were on anticoagulants. However, those have gone off the guidelines, and you can use it in all subgroup of patients who are coming within 4.5 hours. This has become a standard guideline. The SICH isn't high, as was seen in that study. So the next attempt was Epithet. So Epithet came up with a big hope, and what they used were at that point of time perfusion imaging, which has now become a routine. And for a long time, we were not even very clear how perfusion has to be interpreted. So this study looked at the perfusion-based endpoints, and what was seen that till 6 hours, TPA did lead on to smaller infarct growth. However, the study was not powered to look at outcomes, but even the outcomes did show some a better improvement with TPA. But since it was not designed to look at the outcomes, it did not come into clinical use. But we knew that at least till 6 hours, there is some benefit with TPA. The big major trial which occurred after this was the IST3. It was a huge number of patients, somewhere close to 3,000. And they used the outcome scale, which is just like modified ranking scale at 6 months. And they enrolled a big population beyond 80 years of age. Again, did not show any clear benefit. It was as good as treating with placebo. But one thing we came to know that people beyond 80 years of age can be safely given TPA, and with especially the window period of 4.5 hours. And it is this trial helped us establish the age, get over the age barrier. The next came the 9-hour window period, because 6 nobody tried, but this was a new agent. So this also is a, I would say, comes under the rubric of a new thrombolytic. So both the things combined together in this slide. You have a neurothrombolytic agent like desmoteplase, which was slated to be a very, very effective and highly selective, way more selective than tenecteplase. But the first 2 trials, the DIAS-2 was having a signal towards efficacy. However, in the 9-hour window period, when desmoteplase was tried against the placebo, the outcomes did not show a favorable effect of desmoteplase against the placebo. And despite almost recruiting patients up to 7 hours. So we looked at this, and desmoteplase did not it was almost as good as the placebo. So that was out, and nobody has talked of desmoteplase for the last so many years, obviously because it takes a large amount of money to do trials, and I believe desmoteplase does not show any direction. Thereafter, the Wake Up trial, which has already been referred to by Girish, and the Wake Up trial was primarily focused towards looking at patients who woke up with an unknown time of onset. And the primary endpoint was 0 to 1 at 90 days. And looking at patients using MR-based endpoints, where diffusion was positive but flare was negative, which actually equated patients who were within 4.5 hours of the stroke, because that has been proven in previous studies that if you have diffusion positive, then probably the patient is within 4.5 hours. And it did show a good number of patients who were treated with ertaplase to reach the primary endpoint of good outcome with the MRS scores. And this is the shift analysis which we see with the MRS. Definitely a greater number of patients seen in the 0 to 2 arm of the MRS, which is good outcomes in patients. And this was primarily the era, or when we understood what collaterals do. There are certain patients who can go well even beyond 24 hours. You would see that in your clinical practice, and it is believed that it is due to the slow progressors, where your collaterals work on these patients and keep the penumbra alive. And it is believed these are the patients who best would respond on an extended window period. So it is based on these slow progressors that this study of Extend, which was again referred to, and I won't go in detail in this. And this study used RAPID, because it was CT-based perfusion, and RAPID, as you all know, is now commonly used as the AI-based software, which gives us the indication of the core and the penumbra. And Extend was actually prematurely withdrawn, as Hitesh also mentioned, because of the results of the Wake Up trial, and there was no more any equipoise left to talk of. So these patients also considered Wake Up, as well as patients up to 9 hours of the stroke, if the time of onset was known. And the primary outcome was achieved in although the percentage difference was not much, but the effect size was good, where we see the confidence intervals. And ICH, although as expected in the longer window period, was higher, but did not deter the results of a good outcome. And so this is what you see in the shift analysis. So primarily for TPA, we now know that we can go up to 9 hours, 4.5 hours definitely. But if you have the facility for an advanced imaging, you can still go beyond the 4.5 hour window period. You should have a good experience, or at least a rapid software which can tell you, or an MR which is available. Because MR definitely is very useful for patients coming up with a wake up stroke. But one thing we need to remember, that still it is all time dependent. Thrombolysis cannot be delayed at any cost. You know that you can treat late, but you should not delay while giving the treatment to the patient, because for simple reasons, the odds of improvement go rapidly down beyond the first 90. If you see, almost becomes half the chances of recovery at 4.5 hours, and beyond that, again, successively, there's reduction in the odds of recovery. Same graph, we have poorer recoveries and greater chance of ICH as time elapses. And this basically paper is to look at our trends, which we saw a few years back at our center, we published in 2017. And we had progressively over years, we've seen patients increasing in number in terms of the eligible percentage of patients among the eligible whom we treated. And of course, improvement in our door-to needle time and MRS trends also stayed constant beyond the years. So other aspect of EVT is other expanding indications. Again, I won't take much time on this. Most of you would be aware of these, but some interesting. One is wake-up strokes. So I will just skip through it. We just talked of wake-up trial and the extend trial, which has shown that this entity of patients should not be denied treatment if you have the access to the right kind of investigation. And this has come in the guidelines now. So the new 2018 and the 2019 guidelines, the American Heart Association, clearly mention that patients who have an onset beyond 4.5 hours or who wake up with a stroke with the last well-known time not available to us, diffusion flare can be utilized to treat these patients with a diffusion positive and a flare negative. How about minor and improving strokes? Again, this has been a point of controversy since many years. Many times you would face such a situation where the patient whom you're observing or just about to thrombolize, he improves and maybe just left with a minor deficit. What do you do? So this patient, which I often show in our slides, is one of our very early patients when we used to do perfusion as well as angio right at the beginning of our program. And we looked at this patient who was improving but still had a persistent block of the distal M1. And we went on to treat. The patient recovered very dramatically with the MRS 0 within 1 month. Now, at that point of time, there was no data. This is early, somewhere between 2005 and 10. But now we have reasonable data to suggest that minor strokes can be treated. It is reasonable. In fact, the PRISMS was a study. This I got overlapped. The PRISMS was a study which was trying to look at the effect of TPA, but PRISMS could not be completed because of lack of recruitment. There weren't enough patients, and PRISMS was stopped prematurely. It was a negative trial though, but accrued data tells us that treatment of minor strokes is reasonable if within the 4.5-hour window period and doesn't lead to harm. So improving strokes, there are certain indicators that if a patient is improving, what kind of a deficit should you consider as not minor? Clearly, if you have hemianopsia, aphasia, visual or sensory extinction, so these entities may score very low isolatedly on the NIHSS. So do not just look at NIHSS, look at the magnitude of the deficit. You may have a visual loss one-sided, nobody wants to live with that. Aphasia, which could get worse, weakness or even a drift. So we don't usually stop. The only deficit that in our site we stop at is probably just a minor facial palsy. Because if you look at any of the other deficits on the NHSS, one of the most, I would say, severe deficits, indicators of severe deficits is a neglect. One may just score very little on the neglect, but that can lead on, that may indicate a deep-seated lesion or a LVO actually. There are certain predictors of outcome. Again, if you have distal hand weakness, gait, language, neglect, look at these, and these may also help you understand whether these patients are actually minor or not. So the guidelines are clearly stating that patients with mild but disabling. So disabling is a word that we need to remember, not the mild stroke symptoms of the NHSS. So disabling symptoms can lead on to permanent disability, and they should be treated at up till 4.5 hours. Both of these are newer recommendations. Even up to 4.5 hours, these patients may be treated. So these are two separate guidelines. Patients who have non-disabling, the guidelines don't recommend, but that goes on to the discretion of the physician to decide whether you are dealing with a disabling or a non-disabling. So CRAO is one entity which till date had no treatment as far as thrombolysis was concerned, and most of these patients would just be left with their deficit. So a pooled analysis where patients were treated with IV TPA, it was taken up, and patients who were treated with TPA it was found that they had a way higher, greater complete visual recovery, whereas patients who did not, there's a gross difference in the percent. And this was a meta-analysis of few, since there is no clear-cut randomized controlled trial, so it's a meta-analysis which addressed this issue, and we can see that patients, the recovery was way higher if patients, even up to 4.5 hours in one cohort as well as in the meta-analysis, and it was the faster you treated, the better it was. The better was the chance of the recovery. So another entity, this one patient that we treated many years back again, who was treated, but later on it was found the baseline this just looked like a calcified. You tend to ignore such calcification in the folks, but actually this turned out to be a small aneurysm. Patient had a bleed, and it was kind of surprising to look at the 24-hour CT, and patient had a small aneurysm. So if we look at aneurysms, it is asymptomatic aneurysms are going to be very common. The surgeons over here, they pretty well know that a lot of a big population may have asymptomatic aneurysms. So there actually is, and the risk of rupture is not very high in small aneurysms. In fact, none of the stroke studies have ever looked into aneurysms as a risk factor, but whatever data has been accrued, it is now clear that this is not an absolute contraindication, especially if the aneurysm is small. And if there is a suspicion or there is a family history of an aneurysm, a CT angio may be done in these patients, as we know that family history is one of the commonest risk factors, and EVT may be tried. So this patient had a good outcome of MRS of 1 at 1 year. It took a long time for the patient to recover though. And the guidelines also simply tell us that for unruptured, non-thrombosed aneurysms, small aneurysms, less than 10 mm, it is safe to and reasonable to use TPA in these cases. Okay, for recurrence within 3 months, again, this is one entity where we know that if you have a minor stroke, you may not have any risk. And this is an unclear entity till date. And people have treated, and case reports have shown that people do not have high risk of SICH. And this has actually been removed from the FDA label, but the guidelines still tell us not to treat because it is, since it is a general guideline. But one can be selective to see what kind of stroke happened in the past. The guidelines tell us that prior ischemic stroke within 3 months, it may be harmful, so do not do it. But yes, definitely remote small ischemic strokes can possibly be treated. So let's come to the main topic, the newer agents. So now, what should an ideal thrombolytic agent be? Pharmacologically, we should have an agent which should act fast, should be the effect should be predictable, efficacy should be high, low adverse effects should not reocclude, because there are even in fact reports of, in fact, why did MT come in? Because of reocclusion with TPA. It should be easy to administer, simple simple to give, and good effect on the outcomes, and should be cost effective. So desmoteplase was attempted to be created as a new thrombolytic agent at that point of time, but the trials have been negative, and till date there is no other. The guideline simply states do not use any other thrombolytic agent beyond TP and tenecteplase. So what is TNK? Who is tenecteplase? We know that this is a thrombolytic agent which again has a minor structural difference from TPA. It is highly selective for fibrin. If you look at alteplase versus tenecteplase, and the one which I told you, desmoteplase actually has the highest fibrin selectivity. The PI inhibition is also high for this. and half-lives are longer, way longer than TPA. You see this, and that's the reason we can expect that this will have good effects on recanalization. So pharmacologically, definitely TNK is superior, as high selectivity, a half-life which is long, and it can be given as a bolus, not as an infusion, which TPA does. So looking at the pharmacological advantage, it becomes intuitive to understand that this should have been superior and could be superior in clinical use. Uh, and one of the major things which also is an advantage is it causes minimal systemic plasminogen activation. So there is no thrombosis in the rest of the circulation. And a procoagulant effect is also lacking, which has been one of the side effects documented with TPA. The trial started early in 2010-11. A number of dose finding studies, phase 2 studies. So one of the earliest studies for phase 2 3B was trying to look at doses. There was a first trial which was published again in 2012 or 13, and then the first major trial, the phase 2, a test trial. This was published by Huang, the same group which had earlier looked at the pharmacology and the fibrinogen effects. The phase 2 that looked at the primary endpoint, since we were not sure of the outcome effects as well as the effects of the parenchyma. This only looked at the percentage of the penumbra salvage, because this is a good surrogate to tell us whether are we going to go to good clinical effects. And this study, for some reason, did not find differences of penumbral salvaging between TPA and TNK back in 2015. However, it was found to be safe, and although it was not powered to look at outcomes, the outcomes seemed to be better, slightly better in the 0 to 1 group for tenecteplase. However, this was an inconclusive study, and then the big major study in 17 came the NOR test, which a lot of us got excited about, which did not use the dose which was already being used of 0.25. It used a 0.4 dose, and this was a Norwegian study. So they primarily recruited only minor strokes, and it was designed for superiority for some reason. The median NHSS being 4, which is a very minor stroke, and most of them had low NHSS. So what they found was that patients who achieved the primary outcome were almost similar in both the groups. So in the ITT as well as the per protocol. So it was shown that patients who were treated with 0.4, they did okay. There was no high risk of hemorrhage, and there was no superiority, since they designed it for superiority, and further trials were needed. However, 0.4 after this trial came into the guidelines, and it was suggested in the guidelines that patients may be treated with 0.4 with minor strokes. At that point, there were trials still ongoing with 0.25, in fact, a number of trials, which then started getting published, and in between came the TNK in bridging, the extend TNK, which randomized patients before the thrombectomy. Since now in 2016-15, thrombectomy became a standard of care. And patients who were treated with TNK were found to have better recanalizations and better outcomes versus TPA when we looked at the 3-month outcomes if they were given TNK prior to MT in a large vessel occlusion. So this also was a very effective and I would say good evidence which came up with the extend TNK. We clearly see that at 24 and 72 hours, the NHSS scores were way lower for tenecteplase compared to alteplase. So now we knew till now, that 0.4 was safe for as per guidelines. 0.25, a number of studies were being carried out. So NOR test, the same group, the Norwegian, performed another study using 0.4 because they were now confident that this possibly works in moderate to severe ischemic stroke. This gets published 2 months back, and they used all the patients which were unlike the previous study, and they had to stop the study midway because in any case, it was expected, I would say, that 0.4 was not safe, and they had a high bleed rate, and it was prematurely stopped. And yes, and this also matches with the MRS scores not being very high for tenecteplase. So they had to stop the study, and 0.4 is definitely now not, we know it is not non-inferior. In fact, it is inferior to alteplase, moderate to severe stroke. So likely this will go off the guideline very soon, because the guidelines have not been updated after 2019, these two AHA ones. So similarly, just parallelly, taste A came in. This was tested. Again, this results just came in last month. An interesting study where they tested the use of TNK in the mobile stroke units, which are coming up rapidly across the world, and even in India, they are being now used in few sites. And within 4.5 hours, this was ultra early use of TNK, and they again looked primarily only at the uh, perfusion lesion. What is the effect of TNK in the perfusion lesion? So this perfusion CT was done once the patient was transferred to the hospital, not on the baseline, but when the patient got transferred, because you don't have the time, and the patients were given treatment in the mobile unit. And what was found that the perfusion lesions were definitely lower. These are the numbers. If you see the LTEPLS, the number of patients are very small, of course, but this is good enough to look at the perfusion lesions. And patients are the baseline and the final volume. So we see that the volume is way lower for TNK, and this led on to a good effect size and a significant effect size. If you look at the 0.5, and even the confidence intervals tell us that this does lead on to a significant reduction in the box size. So even the use of TNK in the ultra early period, therefore, seems to be safe and leads on to smaller perfusion lesions within the for acute stroke patients and likely to greater clinical recovery. This study, again, very relevant to our population, because this has just been carried out in China on 3 different doses. They tested 0.1, 0.25, 0.32 versus TPA, and interestingly, all the 3 doses matched very well against TPA. All 3 were found to be safe, although the bleeding rates were higher in the 0.32, but all of them have been found to be safe. And so this is kind of a study which matches the population of our country. It gives us some insights. So 2 more studies which just got published. One of them was the SITS data, where our center data was also included. And this looked at inactive place in a propensity score match, just got published in Annals. And so in the propensity score matching, 1 patient of TNK is matched to 3 patients of TPA within the database. And this is the scoring difference, which was looked. If we see this graph, although there's a higher number of patients in MRS 0 to 2, this is without propensity matching. And if the propensity matching is done, clearly there's a greater number of patients, mainly in the 0 to 1 and 2 MRS, which is excellent and good outcomes. So what this study concluded is, on various factors also, if we see the MRS distribution in the propensity matching, they do favor the effect of TNK. And this study concludes that TNK was associated with, in fact, better outcomes at 3 months compared to IVT. But this is not a clinical trial, but it's still an effective, and propensity score matching does give us insights into the effect versus the standard of care, with this TPA. And now this, the most recent publication, the Canadian inactive place trial, which is well talked of now, which is a pragmatic trial comparing TPA with inactive place, again in a large population, only in Canada. Now, and this was a non-inferiority study. It again shows that TNK is non-inferior or is as good as TPA. In fact, the parallelism is well seen in the MRS, and the proportion of patients in the TPA versus the inactive place group are running parallel in this shift analysis. And in the adjusted analysis, so there are almost a difference of 2.1% in the 2 groups, with a good confidence interval which doesn't cross 1. So based upon these studies, we are now quite sure that TNK works well in our strokes. However, it still remains to be entered into the guidelines. The dose appears that 0.25 is the correct dose. Going beyond these, one need not forget that TP is not the end game. There is still way beyond the care, and the stroke unit care is ultimately what all the patients of stroke need. And it is well established in guidelines. And one should offer all patients of stroke unit care, because a comprehensive stroke unit care gives excellent outcomes. And that's for all stroke patients, not just the eligible or uneligible. To summarize, the options we have for acute stroke currently, TPA is evidence-based in the guidelines, so we continue using it. It's the only approved agent, and now we can go up to 9 hours as per the, and especially use it for wake-up strokes. Do not deny treatment to them. They, after using on MRI, for up with the extent you can go up to 9 hours. TNK, as per the guideline, was useful in 0.4, but I think NORTES 2 clearly says do not use 0.4. It is going to be harmful if you use in moderate to severe. Trace for the Asians may tell us the right dose, and 0.25 may be a reasonable alternative to TPA as per the most recent trial, which is just published, the Canadian trial. 0.25 seems to be the right dose, which we might use. It is, we know that it is, the cost is hardly a concern right now, because even TNK comes out to be 30,000, 30 to 40,000 for the 0.25 milligram per kg dose, maximum of 25. But in LVO, it is definitely a good idea to use it before MP. So to conclude, we may be getting late to treat a patient, but you are still on time. The reason is we have so many options with expanding indications of TPA. As yet, TNK has not been tested in expanded window period. I think that's the next thing that needs to be tested once TNK is established as a reasonable alternative to TPA. So maybe TNK also works in the extended time window. We don't know about it till date. But remember this graph that we need to treat as early as possible. So, but look at options just in case you have late patients. And our knowledge keeps evolving. That's what we need to remember. And we need to unlearn our old knowledge to gain new knowledge. Thank you.
Thank you, Professor Khurana. Excellent talk. We have covered the two topics, medical treatment in the antithrombotic and the thrombolytic agents. Are there any questions from the audience side? I think I concluded two important take home message. I think from madam side, two is better. Yeah, is okay, ma'am? Two drug is better, and little bit celestial is the more better if you add aspirin with aspirin. Am I right, ma'am? And from thrombolytic point of view, there is a little bit mistake. This is an anti-thrombolytic agent. I think these are the thrombolytic agent. Okay, sir? These are the thrombolytic agent. These are written in the anti-thrombolytic. You are spoken on the thrombolytic agent. Okay. Is wrongly interpreted anti-thrombotic agent. Yeah. Okay. 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 From your point of view, I think tenecteplase is little bit less costlier and likely to grow over a time, and it will take the place of the altiplase. I'm right?
Guidelines, but evidence does tell us that it is as good as TPA. It works well and may have a better effect in large vessel occlusion. That's what we know till now.
Okay. Like many times when we treat with the altiplase, 1 hour of the infusion all the time with the TENS. Okay, it has to be TENS, but with tenecteplase we are little feel the comfortable. Okay. Thank you, sir. Very well. Thank you.
The only concern that has not been answered till date is the biosimilar. We have no answers on the biosimilar effect, because biosimilar, which is being used in our country, there is no trial on that. So the first trial we are doing now in a bridging paradigm, which is being done by Rohit and the Instruct network, and that might tell us some bit of, because the studies published till now on the biosimilar are basically inconclusive. They're not very high class studies, and we can't draw conclusions. And the dose definitely is low. So 0.2 will not be the recommended dose. We should, if we have to use, is 0.25. That's for sure.
What important take many times confuses symptoms. Patient come to a clinically the stroke, okay, and he come to within time, and we want to treat the patient and thrombolytic. Patient wants, are you sure it is the paralysis? Of course, clinically we say there is a paralysis. When you get done the CT comes the negative. When you can get the MRI, is the negative. When you go through the CT, MRI, all are the negative. And then what we should do? We should thrombolyze on the clinical basis or not?
At the slightest of suspicion, thrombolyze. If we keep waiting for things to happen, for MRI, CT, you lose the time window. That's what I was trying to indicate. We do not need to, prove the fact it's a stroke. Why? For the simple fact, I didn't talk of stroke mimics. Even if it just by chance or bad luck, it turns out to be a mimic, it is very, very safe to even treat mimics. But the risk of treating a mimic is not very high, and in fact, if we do not treat a mimic or a suspected stroke just for the want of added investigations, you will lose the opportunity. And if it's a real stroke, the more you wait, the less is the chance of recovery, and the patient will stay paralyzed. So it is a better idea to treat, to err towards treatment rather than to err towards no treatment. In the long run, that will save more lives. Yeah, we have to be careful. If your CT is normal, no fear. It's only if the CT is showing you certain contraindications, clear-cut indications, contraindications, then we have to, of course, be careful. If the CT is normal, aspect 10, for example, we don't need to show that the stroke has happened. The stroke may evolve slowly. We now know collaterals are there, so strokes may not evolve, but later on they may lose the collaterals and lose the collateral flow, and you may develop a stroke. Especially if CT angio is not there, you may not know there's a big occlusion or not.
Thank you very, very thank you, sir.
Thank you, sir. Now I would request Dr. R.S. Jain sir, Dr. Pushkar Gupta sir to present a memento to Dr. Girish.